We can start. It's 11 o'clock. Thank you very much, everyone, for coming and for your interest in endoscopic spine surgery. We have a masterclass here today. So the concept of this masterclass is that you go to EUROSPINE meeting and you don't just get scientific presentations, but we also present some practical knowledge, stuff where you can go back home and you have something that you can really use in your practice. And that's what we're going to do today. So I'm going to do an endoscopic spine surgery. My name is Christoph Siepe. I'm located in Munich. And I will be doing this together with Verapan Kwansongtam. He came all the way from Bangkok, from Thailand. And Verapan is a really experienced endoscopic surgeon. So we can discuss how I do things, and maybe somebody does something differently. You are more than welcome to stand up, ask questions, and then if I don't hear them, Verapan can come to me and, so that we can really discuss that you get the most out of it. Can I ask anybody raise their hand who does endoscopic spine surgery already? Okay. So who has more than 100 cases of endoscopic spine surgery? Okay, great. So there are some, but many beginners, and we will do some practical tips. If the advanced people here have questions, you can ask advanced questions, but I will also try to give some tips and tricks for people that are really in the early stages, which I think is necessary, because we all know there is a learning curve to endoscopic spine surgery, and some tips and tricks really make your life easier. So this is what it's all about. Can we maybe start with slide number 1? I will show this to you. Okay. Or maybe first we start with showing this model here. So maybe the camera here that shows the model. So this is my patient. This model is nice to explain things. It's not like actually doing the surgery in the patient is actually easier than doing this on the model. The bone works okay. The yellow ligament, the substance is a little bit different. Okay, but the way that you do your surgery is you're standing on the side of the pathology. Let's say if you have a disc herniation or whatever, you do an over-the-top decompression. And now this patient, I'm standing on the left side of the patient. So the anesthetists are here. Normally, the nurse would be standing here, and your assistant is standing on the same side where you're doing the surgery. Later on, you can actually do this. It's basically a one-man show. You can do everything by yourself. In the beginning, it's maybe a little bit easier if you have an assistant. Can everybody hear me well through their headphones? Okay, great. So we mark our skin incision on the patient's skin surface. Okay, so you have your interlaminar window. We have a lot of YouTube videos that maybe you can search after the session. Because a lot of things already depend on where do I make my skin incision. If I have a cranial sequester, I make my incision a little bit more caudally. If I have a caudal sequester, I make my skin incision a little more cranially. If you do an over-the-top decompression, you make your incision a little bit more paramedian. That will help you to go through the contralateral side. Okay, so what you do is you make your skin incision. And what's really nice is this is only an 8mm skin incision, independent of the patient's weight. So it does make a difference if the patient is 50 kilos or 150 kilos, which is really nice, because I very much like to have this technique when you have bigger patients. You always only make the small same skin incision. The next step is you have a dilator. Okay, so that dilator, you just go in with a knife, you go to the spinous process and you incise the fascia, so that you can go with a dilator onto the spine. Okay, can you see this here? That's great. So I go in, I can feel the spinous process. Okay, and I go down, and I'm now on the lamina, and I'm on the facet joint. And you can actually feel there's like a ridge where you go from the facet joint towards the interlaminar window. I can feel this. We don't have an X-ray here now. Like I marked my skin incision before, okay, but that's basically what you do. After that, the sleeve comes in. I'll show it to the camera. So you can see we put the sleeve in like this. So if this is my yellow ligament, my interlaminar window, we put the sleeve in like this, and it prevents that soft tissue is coming in from the side. Don't just stick it in. Okay, so we put it in like this. We kind of rotate it 180 degrees, and now I'm there, and then you can do the access to the spine in 20-30 seconds, independent of the patient's weight, so that's very nice. At the end of the surgery, you just remove everything, you close the wound with just a one single stitch suture. Can we maybe show slide number 3? Because I will give you a quick review how this is being done. Skin incision, the dilator, the sleeve comes on top. You just do one X-ray. This is where it's all located. After that, the X-ray goes in sideways. Basically, you only need one lateral X-ray shot, and then the rest of the surgery, you don't need an X-ray anymore. So that's nice about the interlaminar technique. Okay, so for the beginners here, actually, like when you do a course, the very first thing that you need to learn is how do you hold the endoscope. Maybe we can show slide number 1. So it seems very banal, but you really have to know this in the beginning. It'll make your life a little bit easier. You can see it's always very easy, very relaxed. You know, because some people in the beginning, they cramp up and they say, oh, I've got a cramp in my hand. You know, over time it'll become much easier. So you take the endoscope here. The sleeve is in. The sleeve is on top of the interlaminar window. Okay. But maybe you can show my hands now. Can you see? Okay. So this is how you hold the endoscope. And this is important. You're doing, as a right-handed person, you're almost doing the whole surgery with your left hand, much more. So that means maybe we can, you know, you zoom in and out. You look cranially, you look caudally. So all of these things are being done with your left hand, even when you're a right-sided dominant person. The right hand is always in line with the endoscope. So you can see here, when I'm doing these maneuvers, you know, if you can show my hands, it's all simultaneously. Can you see that? You have to get used to this because when you come from the microscope, we tend to do this. We have a hook, for example, or an instrument. We go cranially, we go caudally. You can't do that here because you're kind of stuck in the channel. Can you see that? So you will only bend the instruments, and ultimately you will only break the instruments. So it's very important that you do these kind of maneuvers. Okay? So that's what we are doing. And the next thing is, so now if we get this camera here, if you zoom in, so this is again how we hold the endoscope. Then sometimes you can maybe show slide number 2, because this slide now explains to you one very important thing. Slide number 2. You can see here that the working channel is located not in the middle, it's located eccentrically. So you can see a lot of beginner surgeons, they stand pretty statically like this, you know, but actually what you need to do is you're always working kind of like this, okay? You go down, you go up. So that's what we're doing. And this is because of the way that the endoscope is designed. Okay, so now I turn on my irrigation. Before we start the surgery, we check all systems, by the way. We check the bipolar. We check the burr. There are different types of burrs. The electricity, all of that is being checked. That's what you need to do before the surgery. Very important. I basically do all of my surgeries with just 3-4 instruments. You can get a whole wide variety of instruments, but basically I'll do all of my surgeries with just 3-4 instruments. I have a Kerenson, maybe 2 Kerensons. I have the scissors here. I have the burr, a dissector, and that's basically it. Okay? So, I start the irrigation system. We did the white balance already. And now we're getting these fantastic pictures from right inside the spinal canal. The visualization, so my upbringing was I grew up with a microscope. The visualization with the microscope is very good. The visualization with the endoscope is even better because your eyes are right inside the spinal canal and you have a 25-degree angled optics, which you can use. So you can look underneath the cranial lamina, you can look underneath the caudal lamina, and you have a huge field of visualization. So I can show this to you here in a video. Can you maybe start slide number 9, the video, just to give you an idea. Can you see this nicely? Maybe, or is it too bright here? So I'm basically flying into the axilla of the nerve. Okay, so I made this video a little bit extreme, but it's really nice to see. You know, you'll never get that kind of visualization when you work with a microscope. Okay, and now I'm starting my surgery here. Ich nehme die Fasszange. Okay. And now I'm starting my surgery. This is what you will see in the beginning. There is a lot of soft tissue, you know, muscle and fascia, and we have to remove this, and we need to expose the interlaminar window. If there are any questions, you know, because I will be busy now for a little bit, and Verapan is now the master of the ceremony here. Yeah, we can take questions, and we can answer them while doing the surgery. Ah, look at that. That's a yellow ligament coming. Okay, can you see? So again, for orientation, this is where I'm standing. This is caudally, and this is cranially on the left side. So the picture that you have is always the same as the patient is lying on the operating table. Left side, patient's head, cranially, feet of the patient, caudally, okay?
And in the real patient, before you face the ligamentum flavum, you will see the last layer of the muscle and the fat. So sometimes you cannot differentiate, is the fat above the ligament or is the epidural fat in the beginning. So you can do a lateral x-ray to see how deep you are to tell the difference. And when you insert the dilator that is too resistant, it can be the fascia above the muscle or it can be the ligamentum flavum. In the AP, you cannot tell. Sometimes you flip to the lateral x-ray and you see if you're not deep enough, you have to make a cut with the knife on the fascia and put in dilator again.
Yeah. Okay. So I have removed my soft tissues. This sometimes is a little, for beginners, this can sometimes be a little bit irritating. It can take some time. If we have time later on, I can show you how to stop bleedings. It's very easy, actually. You know, we have a bipolar that maybe I can show you quickly.
Yeah. So as you see that Professor Siepe is handling the scope with his left hand. There are the rotation movement, left and right caudal cranial, up and down to zoom in, zoom out, and the joystick motion. So the last motion you want to do is the joystick motion because it can create bleeding. Okay, so when you want to look up, you rotate the scope first. If you cannot reach, you move like a joystick later. Yeah? And if you stay in the window, not go above the lamina, upper lamina, or too lateral, you will not face with the serious bleeding.
So this is an important step. I recommend to all beginners that you start with cases at L5S1 where you have a very wide interlaminar window where you don't need to use the burr. Using the burr in the beginning is technically a little bit demanding. So maybe do your first cases, L5S1, easy discectomies, until you feel comfortable. And in those cases, you can already try to use the burr. So there's a trick here. So this is a case L4-5. L4-5 is already much more difficult, generally speaking, than L5S1 because the interlaminar window is much smaller. The nerve root is exiting in a different way. You must be able to use the burr. If you don't do that, darf ich mal einen Dissector? If you don't do that, because you're not feeling comfortable with the instrument, and then you try to go in here with a dissector, then there's a high risk that you will injure the nerve root. Okay? So you need to create space lateral. So at L45, you need to use the burr. That's what I'm doing now. So you insert the burr, you get all different types of burrs. You get sharp burrs, you get diamond burrs. I usually do everything with this particular burr, and you can see that there's a protection, a shield medially. Now the trick that I can tell you is the sleeve is standing on top of the facet joint. Can you see that? And that way you can easily maneuver up and down. If you just slip 2 millimeters too deep, like here, now I'm stuck. Yeah, and now you can't get anywhere, and then, you know, surgeon's getting angry and impatient, you know, and you break the instruments maybe. So the trick is easy. The sleeve goes back. You're standing, can you hear me? More like this. Yeah, so this is the trick. Okay, and now I start the burr. The next thing is we will be working in very close proximity to the nerves. So you need to be 100% sure that you don't accidentally slip inside. Maybe you can show my hands for a second. So you don't hold the instrument like this. I'll show you. You hold the instrument like this, and now you can see here, if you zoom in, my ring finger is basically standing here on top, okay? So I always know the depth of the burr, okay? And that makes it a lot easier. So, and then you can use the burr. We need to open up the interlaminar window. Okay, that will take me some time. So Verapan, you can maybe take over for a second because I'll have to do some work here.
So as you can see, Professor Siepe is handling the scope with the left hand to go everywhere with his left hand. So the right hand is just control the depth of the drill. And sometimes if you want to do back and forth movement, like rubbing the bone, but nothing more with the right hand, only with the left hand. And normally before we drill, we have to do the soft tissue preparation. We have to detach the superficial layer of the ligamentum flavum for the facet from the facet capsule. And we have to identify the tip of the descending facet and up to the upper lamina, and identify the body part of the lower lamina as well before we start the drilling. So normally the superficial layer of the ligamentum flavum insert on the dorsal part of the descending facet and on top of the lower lamina and insert underneath the upper lamina. So you want to make a soft tissue dissection before you start to drill. So I think right now it's cutting the base of the ascending facet and the lower lamina.
So here is the part where we have to play around with the model a little bit.
Yeah.
Fräse nochmal. So what we do in a discectomy case, I will show this to you. So what we can show right now is if you can do the slide number 4. Slide number 4. Fräse für mich. Slide number 4. Okay, cool. And you have to start the video. So you can see the yellow ligament here has a completely different consistency. This is how you do it normally. Okay? So you have the scissors and you can cut the yellow ligament really nicely. So in the discectomy case, I only make a very small incision into the yellow ligament just to be able to enter the spinal canal. This is obviously different. So you can see, I only see the nerve root there. The majority of the yellow ligament of the dura is still intact, which is nice. If you have a recurrence, for example, you can still go back at a later stage. Okay, and then there's no scarring, so that's actually quite nice. But here, we have to play around with this model a little bit. Ich nehme mal die Fasstange.
So
So because the model is just a model and it's not a real live cadaver. Okay, wo kommen die
Maybe
Luftblasen her gerade? Where do the water bubbles come from?
more water. Yeah.
Wasser noch voll? Ruhezustand zurückwärts? We need to refill the water here a little bit. Haben wir?
So in the real patient, we use the spine mode that it will control the flow and it will not exceed the certain pressure, which will not harm the patient. So normally, the design of the scope, the sleeve is round, but the scope itself is oval. So there is one input of the water, but the output of the water is coming through the working channel and between the scope and the sleeve. Okay, so that's a safety that you will not face with some rare complication such as blindness after the surgery if you don't have a very good system and you pump the water in all the time and it's not coming out efficiently.
So this can also happen in a real scenario, Fassanger, when you don't change the water bags quickly enough, then the system might have some water bubbles. So then you just need to wait for 30 seconds and it gets better. So this is actually what I would like to show to you in a spinal stenosis case where we go cranially. And in a spinal stenosis case, I detach the yellow ligament from its cranial insertion.
This is the upper lamina, right?
Upper lamina, that's right. Any questions from the audience?
Yeah, so the upper extent of the decompression, normally you have to go beyond the tip of the ascending facet. Or you can go even to the insertion of the ligamentum flavum underneath the upper lamina. And we confirm by X-ray.
Yes.
And the lower extent, we go to the mid-level of the lower pedicle, please.
Das ist die Luftblase. Machen wir ganz kurz. Mit einer Kompressor. Ah, das ist schon weg. Dissector?
Okay, the question was, do you have the firm contact with the sleeve to the bone at this point?
The question was, I can repeat it? Oh, no, you did already. Okay, yes, I do have firm contact with the bone. You can see that here? Okay, if you don't have firm contact and you're too far out, then you have all soft tissues coming in and you can't see anything anymore. So the sleeve is always resting on top of the bone. So you can see there is a small opening now, and you can see this is how I do spinal stenosis cases. So in discectomy cases, we only want to create a very small opening into the yellow ligament, okay? Keep the rest of the yellow ligament intact, unless we have a case of disc herniation and spinal stenosis, and we obviously do decompression also. If I have a spinal stenosis, then the yellow ligament is my underlying pathology, and then we really want to remove the entire yellow ligament. And the concept for me is pretty much the same, like when you're doing a micro decompression. So in these cases also, I go all the way to the top insertion of the yellow ligament, we pull it down, and then we start resecting layer by layer. So what you should not do endoscopically is you just cut down in one line. You resect the central part is decompressed. And then you do the next line. And then you go outside to the bone and you do the recess decompression. Until we can see, now we're standing on the left side, at 4 o'clock you need to see the exiting nerve root fully decompressed. I'll show this to you quickly how I do it in a decompression case in a real surgery. Slide number 5, please. Okay, nehme ich mal einen Dissektor. And there you can see how I detach the yellow ligament from the cranial insertion. Okay, ich nehme die Fasszange. So I first start to do that procedure with the scissors. Then I start using the Kerensons. I first use a small Kerenson, Then I take a bigger Kerinson. Okay, was that clear in the video? Verapan, this is how I do it in a decompression case. Do you do it the same way, or do you have another strategy? I mean, there are always many ways that lead to Rome.
I think it's more or less the same because from the decompression, the ligament and the facet itself is a pathology. So we attack the insertion from the upper lamina down to the lower lamina. And normally, when I drill the bone, I will cut to thin the ligament at the same time. Because if you don't cut the ligament, it will become a lot of ligament coming out and obstruct the view of the deeper ascending facet. So I thin the ligament from time to time until I see the natural groove between the ligament right side and left side. And then I use the probe to create to widen up the natural groove and remove in two pieces, right side and left side. Yeah. Some colleagues, they remove in one pieces. I think it's not necessary. And before you remove the ligament, you have to flip the ligament and see the epidural. Sometimes with the severe stenosis, there is an adhesion between dura and the ligament, and there's an epidural bleeding all the time. So we will reduce the coagulation to 20 to 24 to coagulate epidural vessel underneath the ligamentum flavum before we take it out in the stenosis.
I think, Verapan, a while ago, I saw you that you create like a real, so you can see the dura is coming, okay? And now everything is straightforward. What I want to show you, the most important thing is you can see that you can see everything. And that's what makes the surgery safe. You can see the dura, you can see the nerve, then you can protect the dura, you can protect the nerve. You know, a lot of things now are basically surgeons' philosophy. Do I think I have done enough decompression? Do I think I should carry on removing more adhesions or not? But you can see that you can basically see everything. And Verapan, I think I saw one of your videos once where you like take a big flap and you remove that flap completely, right? Is that what you meant?
Yeah, but before I do that, I have to flip the ligament and I have to make sure that there is no adhesion between the dura and the ligament.
Yeah. So what I want to tell you now, so this is how I always do it. And what I did before, I was kind of cheating because I know the model. And the yellow ligament doesn't have the consistency of a normal yellow ligament, not quite. So, so what I'm doing is, or what I did, is just to get my entrance a little bit, you know, I do this and I pull. You don't do that you don't really do that.
In the real patient.
The real patient doesn't
when
work.
You pull, it will not come
Here
out.
it works. So that's my way around.
You have to cut it.
Yeah. Okay, große Schanze nochmal. So this particular Kerinson, that's my favorite instrument. And you can see it's like a little bit angled. Helps you to get in here. Helps you to get to the other side. You do an over-the-top decompression. So basically, you know, this technique is evolving, and basically you can do every surgery also endoscopically. The question is, do you feel comfortable to do an over-the-top decompression or a synovial cyst or a cervical spine with the endoscope? So in that respect, it's not so much the technique. It's more like, do you feel comfortable already doing this? Or, you know, in my eyes, patient safety is always first. So if you're not sure, then maybe, you know, say, okay, maybe not yet. Maybe I'll do it in a year's time. Okay. But basically, generally speaking, you can do everything also with the endoscope.
Yeah.
Okay.
So normally, when we do one side decompression for the recessed stenosis, it ranges between 20 minutes to maybe maximum 40 minutes for the very difficult stenosis one side. Over the top, I do 1 hour to maximum 1.5 hours. So the difficulty depends on the bleeding, especially the bleeding from the bone.
Yeah.
Yeah, it's quite demanding to stop the bleeding.
You're
so
right.
the epidural bleeding, the vessel bleeding from the muscle is not that much. But the bleeding from the bone, especially with a lot of degeneration, that will slow down, and try to work with the bone and the ligament. Don't rush to the dura, because once you open the dura and you have a lot of bleeding from the bone from anywhere, you will slow down the surgery by yourself because you are afraid to cut into the dura. So do the bone work, finish all the bone work, thin the ligament, and then when you feel comfortable, you stop all the bleeding, and then you enter into the spinal canal.
So
That will shorten the surgical time.
so you can see here, this takes now a little bit of patience from my side. We have to just take a bite and another bite and another bite. But I think it's nice for demonstration purposes. You get a good idea. You know, this procedure is safe. There's no chaos. I fully agree, Vera Pan. You know, the bleedings, you must really make sure that you control bleedings right from the beginning. This is a very important corner down here, because later on, just now, we will see the nerve root exiting down here. And there I will also show you a very important maneuver. So as said, you can play with the optics, 25-degree optics, looking down, looking up, okay? I can also show you how to work with a burr on the bone just now. Now that the spinal canal is open, so this becomes much more delicate now.
And that's a dura, right? The white thing.
There's a dura.
Dura.
This is a dura. There's yellow ligament still. That's what we want to see. We want to see the lateral border of the dura. And then here you go, okay? Now that becomes clear. That's exactly what we want. And now you know, things are starting to come together. Okay, we want to do a little bit more of the decompression here in this area. Some of the models, they actually have a disc herniation built inside. That's very nice.
And in the real patient, you will face with the epidural fat and epidural tissue. You may not see the shoulder of the nerve immediately. So another thing that is very important step is to remove the epidural tissue, and in order to identify exactly the border of the shoulder of the nerve.
If there is anything that you want me to show you, like how do you, just come up here to the microphone. This is all very
Any questions?
nice, relaxed, get together. You can see the exiting nerve root coming. There's a question here. Yes, please.
Who? The microphone doesn't work. I cannot hear you.
You can repeat it. You said, please control the bleeding of the bone. How do you control the bleeding of the bone? I cannot use bone bags.
The question was how to control the bleeding from the bone. So normally when you use the drill, try to put the scope as close as possible to the drill, because there is a water flow. Okay, when you face with the bleeding from the bone, if you still can see and the ligament is still closed, keep drilling. The bleeding will stop unless you face with the big chunk in the bone. So you can use coagulator and try to have a smooth surface on the bone that you can coagulate. If not, you use the probe to direct compress the bone to stop the bleeding. So most of the time it's like that. I never use the bone wax, because you cannot put through the working channel. It will stick in the working channel, okay? And some patient with the aspirin and the bleeding come from everywhere, and you do everything and it doesn't stop. You pull out the scope, you put in the dilator, you wait 5 minutes. And then when you go in again, you face with the clot, okay? So you remove the clot, and then you continue surgery. In the worst case, sometimes I use flow seal, okay? Put the flow seal, some cc, wait 5 minutes, go in again, but you have to wash it out, and then you continue the surgery. But that's maybe less than 4 to 5% of the case.
Maybe we can show video slide number 6, please.
please.
Because I'm going to show you a very important, just maybe 1 second. I want to show slide number 6. This is important. So you can see how we go in lateral of the nerve root. We mobilize the nerve. And then we take out that disc herniation. Okay? Because often you see people that start with this technique. Darf ich meinen Dissektor haben? And that's exactly what I mean. Okay, now maybe we can show here the camera on the hands again, on my hands here. You can see there is a risk when you go in like this, you know, that you
inside.
squeeze the nerve. Okay, so you must not do that.
Okay.
Please, everybody be very careful, nerves, delicate structures. So what we do, there's such an easy trick, and that's, I showed you the anatomy of the endoscope. Working channel is located eccentrically. So what you do, there's a very easy maneuver, and these are these small little things that make your life easier in the beginning. So what you do is you go down, if you do it like this, and you squeeze the nerve root or the dura, okay? So I rotate the endoscope, I go down, and rotate back. And now everything is very safe. Can you see that? We never squeeze the nerve root and manipulate it, and okay? So it's very easy. So if I do it just straight like that, I'm only operating very rigid, you know, like almost robotic. It doesn't work. So we go in, we rotate the endoscope, we go down carefully, we protect the nerve, and then you can use this like a retractor. There is a maneuver that you go in with the sleeve. I'm doing this now. And then you can use the sleeve to basically use it like a retractor. I'm just telling you, there's a little water bubble here on the camera. Okay, now we go. I'm just telling you, please be careful, do that, or maybe don't even do it. You know, experienced surgeons, that it's a different story, you have different eyes. In the beginning, you are so focused on so many things. You know, there's the handling, the everything is different, the anatomy is different. And then you don't see, maybe, that when you do this, you're actually squeezing the nerve root here. Can you see that? 4 o'clock? 4 o'clock? So please be careful, or maybe don't even do it. That's my recommendation.
Yeah.
There are so many other tricks that you can do. Wollen wir die Fasstange? In order to get out a disc herniation. So if you have a contained disc, then usually what I go in with a dissector, I puncture the posterior longitudinal ligament, and goes pop, you know, and the disc herniation comes out, and then you can take it out like this. I'll show you a trick, another trick, and I named it the crocodile roll. Slide number 7. Dia Nummer 7, bitte. So basically, like a crocodile bites its prey and twists around. That's what you can do here too, okay? So you twist it 2-3 times, and then you pull out the whole disc herniation. That kind of helps, okay?
Yeah.
So that's the crocodile roll.
So
there are so many maneuvers. You don't need to go into the spinal canal with a sleeve. I really recommend that you don't do that.
This is very important. So most of the dura tear happens when you don't see the border of the dura and you squeeze on the dura. Is the most common. And before you remove the free fragment, most of the disc herniation is a subligamentous. You have to cut the PLL more or less. And then you can squeeze this one and then put it out, and you retract the nerve later. Because if you retract the nerve at the beginning and the compression is still there and you are not very fast, you can create double compression, and that's when the complication happens.
So what you can see now, we've done the ipsilateral, you know, we've done the central decompression, we've done the ipsilateral recess decompression. If you like, I can take the drill and take this away, but I don't think we have to. We only want to take away as much as needed, but I could take this away just for demonstration. And now I'm starting to do an over-the-top decompression. It's also possible. Okay, große Stanze geradeaus. And actually, that is not so much of a big deal. You basically just tilt the endoscope. There you go. And you go to the contralateral side. When I work on the ipsilateral side, then I take my instruments, most of the time I take them backhand. Going to the other side, I take them forehand. And now look at that. The visualization really is fantastic. I showed it to you. The visualization into the contralateral recess. And the reason is, again, our eyes are inside the spinal canal. And look at that, there's a contralaterally exiting nerve root coming down here then. You will be able to see that. Okay, here you go. As with microscopic surgery, please be careful. Don't push down with your instruments on the contralateral exiting nerve root if you go into deep, okay?
And this is a very powerful correction, but be careful if you are not sure that you are lateral to the nerve, the traversing nerve, and you use the 4 centimeters big correction, you can compress on the traversing nerve. So you have to be sure that you drill enough, that you insert the correction lateral to the nerve.
Are there some?
There was a question from the lady that how many cases in the cadaveric training that we need before we start the procedure with the patient. So we talk about interlaminar. Transforaminal is another training. It's a different technique. So for interlaminar, normally we provide a workshop. So for the single participant to finish the approach 3 times in one day. And then maybe next day or next week, you can go and start with the patient. So there's a training in Vienna, in Munich, I believe, and also in Bangkok, more than 3-4 times a year.
So you can see here there's a contralaterally exiting nerve root. We can take away more of the bone in the contralateral recess. We can use the bone, the burr here in this area also. I can do that. But you can see already that's a contralaterally exiting nerve root, okay?
Check, check.
So you can see that you can see everything. We can use the burr, and I think there's one thing that's very important for everyone here. I sometimes hear, you know, like, what is the learning curve? That's always one of the questions. And then you hear the most crazy things. You know, it's like 10 cases, 20 cases, 10 or 20 cases. You know, I think you just have to be very honest with everyone. You know, you don't do the over-the-top decompression and the cysts, and you know, it gives you a first idea of the technique, but you really need more time. Okay, that's just the way that it is. But that is the time that you need to invest in yourself if you want to learn the next generation's surgical skill. That's my opinion.
Yeah,
so you can see here just quickly. I can use the burr going to the other side.
Switch to the endoscopic view.
Oh, sorry. Maybe we switch to the endoscope.
There's a question, Siepe?
Question, please.
Just quickly. Yes. Here, I'll show you how I can use the burr going to the other.
Hear me? Okay. I'm Cesar from Brazil, and I just...
1 second, please. I'll just quickly show you. You can use the burr to go to the contralateral recess and to use the 25-degree angled optics again to look into the contralateral recess. And then I can take away more bone here also. Okay, sorry? Okay. Sorry for interrupting.
I'm Cesar from Brazil, and I only perform the monoportal techniques.
Yes.
And, I don't know if my question is appropriate, but I want to know about both of you. If the comparison of the monoportal and biportal, what's the advantage and the disadvantage between them?
You mean the comparing biportal
techniques.
And uniportal?
Can I answer?
Yeah, please.
I'm burning to answer that question. The biportal technique is easier to learn, and it's cheaper in many countries because surgeons can use their arthroscopic systems. You will not see people that are comfortable with the uniportal system going back to biportal. And in my eyes, it's just more invasive. But it's cheaper and it's faster to learn. That's my opinion. What do you think, Verapan?
I think there is advantage of the biportal over the microscopic surgery. Because microscopic, basically, you're looking from outside the patient. Okay, and when you want to look to what you are doing, you put instrument on the right side, you look from another side, as like a triangle. It's the same philosophy with the endoscope, but you're looking from inside and you can rotate the scope. But I saw many colleagues that use biportal. They put endoscope in to look, and they don't move the endoscope. They don't look around. So it's like microscope, but looking from inside. But if you use biportal and you look around, like a uniportal, or even with the uniportal, if you don't rotate the scope to look around the corner and to see the tip of the instrument all the time. So you don't have the full benefit of the endoscope. So in my opinion, biportal, like the setting is easier if you have the auto, like I'm not orthopedic. If you have the set already for the arthroscope in the hospital, you can use that. But with the uniportal, you need a different set, and the learning curve is more demanding. But at the end of the day, if you are patient, you want 1 hole or 2 holes. That's the point. But in my opinion, if you can finish the surgery safely, it's okay. It's okay.
So we are slowly but surely coming to an end.
Yeah.
I just wanted to show you maybe one more trick with the bipolar. The bipolar is one of the most important instruments of the whole surgery.
Yeah.
Because, here we go. You can see the bipolar goes out sideways. You use it to coagulate bleedings. If you don't apply electricity, then you can use it as a hook. I very much like this to get rid of adhesions because it's very soft and delicate. You can see the tip is round and it bends. When you use a dissector, then you immediately apply pressure. Here it's very nice because this instrument bends, okay? So you can use it to separate adhesions. You can use it to carefully mobilize. You can coagulate bleedings also from the surface of the bone. So that's very important. You need to check the bipolar before the surgery. If you apply electricity, please only apply short impulses, like zzz, 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 okay? This is a 4 megahertz system. So it applies the heat very locally just around the tip here, which is good, which is important. So there's not too much heat going elsewhere. But still, you only apply short impulses. That's very important. And the next thing is make sure that here with your pedals on your feet, you click coagulating and not cutting, because cutting the electricity is much stronger. Okay. There's another question, one more question, and then I think we've actually come to the end of the session.
Thank you for your live case, sorry. A quick question about the drilling. What is the average speed that you use?
Yeah.
And then are there any cases that you need to go higher or lower?
I always have the same speed. I adjust it at the beginning of the surgery. You can do it 6,000 or 8,000 or 10,000. One thing I do before the surgery, I usually have it on 8,000 rounds per minute. One thing I do before I start the surgery, I take a syringe, I put in some water here so it lubricates the burr a little bit. Otherwise, you can do everything with 8,000 rounds per minute.
Yeah, it's the same for me. I start with 8,000. Sometimes I go to 10,000. But if you go for more, you will feel that the handle cannot handle it. And the most important thing is don't press before you press. Okay, if you press against the bone, it will slip. And you always take out the drill and wipe it, because the bone dust between the drill and the working channel will obstruct the outflow. And always use the suction on the drill to suck out, okay? So to answer the biportal question, so I use biportal when I do the T-lift, endoscopic T-lift. I use another port to insert the cage. Yeah, but decompression, no.
You see this video? Now we've done our surgery, okay? You simply remove your instruments. You do one single stitch suture and maybe Dia Nummer 15, das letzte. And then we finish our surgery. Okay.
Siepe,
slide number.
Tomorrow we have a lunch symposium.
Yeah. Maybe slide number 15. This is coming. We did some nice teaching videos for everybody who's about the anatomy, the preoperative planning. You can see this is quite fancy with a green screen video. It's also coming, so just, we must stay in touch, and then over the coming weeks you will see that we have something here for beginners, for advanced, where to do your skin incision, how to hold the instruments. We really try to explain things, so that's coming, and that I hope will be nice and helpful for everyone. So thank you very much for joining. Thank you very, very much, Verapan, for coming all the way here. Frederick, And for everyone here from the tech team, that was really, really nice. Thank you very much, and thanks for coming.
Thanks for coming. There will be the. I will show the technique for the cervical at the 350 at the booth. And tomorrow we have the lunch symposium together with Professor Siepe, Professor Rutten, and Professor Com at noon. Stalls 2, room stalls 2.